Alrighty. Hello guys, I'm back. My name is Chad and we're just gonna continue on our respiratory part 2 guide. At the end of the part 1 guide, I was talking about respiratory, acute respiratory failure, and then the priority assessment and assigning symptoms, and then I stopped at diagnostic and labs. So you can tell if someone has a respiratory issue by cyanotic. They're gonna need some oxygen, so some nail beds, scan, lung sound, respiration rate, everything's gonna be affected. ABGs, just X-ray. You can do all these tests to make sure to actually, like 100% sure it's an acute respiratory failure. Treatment: you need to treat the underlying cause and maintain adequate cardiac output and hemoglobin to maintain adequate nutrition therapy and also maintain the protein and the energy stored. That is your number one. That's why it's highlighted in red. Oxygen, of course, airway suctioning, and increased mobilization of the secretion. Drug therapy, of course, you're going to get bronchodilators, steroids, diuretic and nitrates, IV antibiotics, IV hydration, chest physiotherapy, airway suctioning, ambulation, all these kind of stuff that you do for respiratory issue. You're going to need to do all these. So the patient position, there is three positions. The first one is the tripod position. Tripod position is used to increase the chest and the lung expansion, decrease the work of breathing for the patient with COPD or asthma. And that's what we tell them to do. Effective coughing, the huff coughing, the staged cough, and the augmented cough as well. Let's talk about PE. Pulmonary embolism basically is a blockage of one or more pulmonary arteries or tumor tissue, fat, or air embolisms. So basically the lobes are mostly affected by PE. They're the most affected actually by PE. Most of the PE's patients die within an hour because the gas exchange decrease and no blood supply to that alveoli. And here's the picture. You can see it, the heart and the PE and where it stops, and it decreases the oxygen, decreases the flow. Risk factors. Okay, so basically PE, pulmonary embolism, risk factors are immobility, surgery, smoking, heart failure, clotting disorder, obesity, and any history of DVTs or an actual DVT. Sign and symptom is going to be dyspnea, tachypnea, cough, chest pain, wheezing. Complications, it could be pulmonary hypertension or death of the tissue. Diagnostic studies, you can do ABGs, X-ray, you can check the troponin levels to check for a heart failure, and of course electrocardiogram and a D-dimer. Nursing intervention, what you can do is the prevention, right? You don't wanna have it, like deal with it when you have it. You want to prevent it, right? So compression devices, early ambulation, prophylactic anticoagulation, Lovenox, and all these kind of stuff. You want the management, you want to semi-followers with physician, oxygen therapy, frequent assessment, IV access, and you want to monitor the labs. Teaching, long-term anticoagulants, you want to measure the preventive the DVT as well. The goal of the treatment is to prevent further thrombi. You want to provide a cardiopulmonary support, oxygen, ventilation if needed, and of course fluids and diuretics and all these kind of stuff. I talked about the anticoagulations. You want to make sure that the IV heparin, the BTT, is between 1.5 to 2.5 or 40 to 90 seconds. That's going to be in your exam, so make sure you remember this and comment in as well. Now ARDS. What's ARDS? ARDS is basically a sudden progressive form of acute respiratory failure. It's not a disease, it's just a lung dysfunction, right? So what happens is the what happens basically, it just end up filling with fluid. Causes, the direct cause is basically aspiration, toxic fumes, lung trauma. Indirect would be asepsis, shock, trauma, or blood infusions. Injury phase, basically the work of breathing is high respiration rate, and low tidal volume. This, I mean, you can just look at the picture, but you don't really need to know this. Clinical manifestations, you can tell if there's early signs and late signs. Early signs is like dyspnea, tachypnea, cough, ABGs, or there's a mild hypoxemia, or it's just auscultation. Late signs can be like tachycardia, diaphyses, change in LOC, cyanosis, anything changing in LOC, is serious and something is not right. Hypoxemia is a literally hallmark sign of later they tend to get hypoxic. Complications, it could be a VAP, elevate the head a bit 30 to 45 degrees. Daily oral care. Respiratory therapy, you can do like O2 administration. The goal is to correct the hypoxemia, right? So you want to start the nasal cannula, then go up to high flow and all that kind of stuff. Modest to severe ARDS needs ventilation and intubation. Positioning is really important, and you need to know this, right? Because you want to turn the patient from supine to prone to help reduce inspired peak or the O2. So that's called proning. You want to make sure you know what proning is, which is this one. Make sure you know this. You have a continuous lateral rotation therapy, which is basically, it's just a continuous slow side to side. It's just turning side to side, less than 40 degrees. And it also performs physiotherapy. So here's the proning, and this is the STLRT. You can see here. After intubation, you want to make sure you auscultate both lungs, right? If the tube goes down the right side of the lung, no breath sounds on the left side. The doctor may ask you to pull the intubation tube back up. You have to get an X-ray to make sure it's in the right place. You want to make sure you document if you removed the tube or pulled it or replaced it or whatever you do. You want to make sure you document that. And you do want to do AVGs 30 minutes after the intubation or according to the orders if they want it more often. Remember, respiratory therapists will take over and control the ventilator. If the nurse makes any changes, make sure you let the RT know. That's really important, right? And it's really important to know what's going on, like what kind of fluid is coming out. So like you want to remember suctioning, right? When you suction, what color is it? The consistency, amount, is it moderate, pink, white, clear, black? You want to make sure you know all these for your exam. And if you have any questions in regards to respiratory, you just let me know. I can tell you what's important right now. The rib fracture is important. You want to make sure what you do with it, what you give. The cardiac tamponade is really important. I mentioned earlier. Sorry, so I'm back. Yes, so you want to make sure you know about the cardiac tamponade. You want to make sure the signs and symptoms. When you see like muffled, distant heart sounds, that's automatically cardiac tamponade. When you hear hypotension, JVD, cardiac tamponade. You don't have to think about it twice. They love to ask about the signs and symptoms. Here's some, like if you have a chest trauma, I've said that before earlier. I'm just like, putting it out there just in case if you guys need watch out for excessive bubbling in the water seal if you have a chest tube. And that's pretty much it. If you guys have any questions, any concerns, any comments, please just drop them in the comment and I will answer all of them. Thank you.